Hello, my name is Davtian, and today I will be presenting a case study for my keto rotation. Starting off by introducing the case study patient. JP is a 2-year-old male who was admitted to Children's Hospital Los Angeles on November 3rd, 2020 for initiation of ketogenic diet therapy for seizure control. His admit weight was 8.97 kilograms and his length was 85.5 centimeters. JP has an array of medical diagnoses, but for this case study in particular, I will be focusing on the diagnosis of infantile spasms. For some background information, JP was born at 32 weeks via elective C-section, secondary to fetal demise of twin B at 15 weeks gestation, which is the clinical term for stillbirth used to describe the death of a baby in the uterus. This patient has developmental delays and receives his sole source of nutrition via G-tube. He lives with his mother, father, and older brother who also has a medical history of seizures. To add to background information, I included his previous admission history ranging all the way back to 2018 to provide a better understanding of the patient's ongoing health matters. For his current admission on November 3rd, JP was admitted to start ketogenic diet therapy to possibly assist and better control his infantile spasms. Infantile spasms is defined as a seizure disorder in babies which makes muscles in the arms and legs stiff and the head bend forward. The spasms start suddenly and last a second or two, and these spasms often come one after another in a cluster that lasts for several minutes. Infantile spasms are caused by brain malformations, infections, brain injury, or abnormal blood vessels in the brain, but sometimes the cause is unknown. These spasms are diagnosed by a pediatric neurologist who will typically request blood and urine tests to test for infection and illnesses. In addition, an EEG or a video EEG will be performed to test brain waves and electrical activity for proper diagnosis, that is. And also scans will be obtained to look inside the brain. There are several treatment options for seizures. The first category of treatment includes anti-epileptic drugs and steroids, in which the most common and effective ones are adrenocorticotropin hormone, prednisolone, and vigabatrin. Another treatment for seizures includes surgery in which an area of the brain can be removed to cure seizures, or an interruption in the nerve pathway is triggered to provide relief of seizures. And lastly, a non-medical treatment for seizures is the ketogenic diet, in which will be the treatment choice for this particular case study. The ketogenic diet is a high-fat, low-carb, controlled protein diet that has been used since the 1920s for treatment of epilepsy. The diet is a medical treatment and is usually only considered when at least 2 suitable medications have been tried and have not worked. The typical classic ketogenic diet, called the long-chain triglyceride diet, provides 3 to 4 grams of fat for every 1 gram of carbohydrate and protein, which is about 90% of calories from fat. Other forms of keto diets, which are less strict, include the modified Atkins diet, the MCT diet, and the low glycemic index diet, which offer much more variety. But for this patient, we will use the classic ketogenic diet as a form of treatment. The keto diet ideally mimics a fasting state by metabolizing fat instead of carbohydrates for fuel, which then results in the production of ketones. The fats consumed are broken down by the liver to form ketones, and the ketones are released into the bloodstream, which then travel to the brain for energy. Since the ketogenic diet is high in fat and low in carbohydrate, there are nutrition-related factors to be considered, which often include issues with growth and development. Since the diet is limited, oftentimes the patient may not receive complete nutrition just from diet alone, in which multivitamins are often recommended. Constipation may occur, in which dietitians may recommend increase in fluids, increase in fiber-rich keto-friendly foods, incorporation of MCT oils, and also using Miralax if necessary. Acidosis may occur, in which RDs recommend incorporating some type of buffering agent such as baking soda or F or K, to treat acidosis, which also may help those patients with kidney stones. For patients that experience hyperlipidemia, RDs may suggest decreasing saturated fat intake and maximizing intake of unsaturated fatty acids. And RDs may also lower diet ratio. Lastly, anti-epileptic drugs can cause weakening in bones, so it is recommended for this population of patients to supplement with vitamin D and calcium to improve bone health. So now that I have discussed some background information about JP and the ketogenic diet and how it works for someone who experiences seizures, I am going to move on to the nutrition assessment portion of this case study to further explain an appropriate treatment for this patient. Starting off with Anthros. During admission, his weight was 8.97 kilograms. 2 months before that, the patient weighed 9.3 kilograms, which is roughly a loss of 5.5 grams per day. And possible reasonings for that may be due to a recent C. diff infection. For his corrected age, his desired weight velocity should range between 4 to 9 grams per day. As for his length, measurements were a bit variable, showing an increase from the 4th percentile to the 43rd percentile. But typically for his corrected age, a desired length velocity is between 0.19 centimeters to 0.26 centimeters per week. Now moving on to biochemical assessment. When a patient is admitted to the hospital for a keto diet initiation, the entire process takes about 3 days in order to appropriately monitor tolerance to diet. In order to monitor, an array of labs are ordered to obtain blood glucose levels every 4 hours, urine ketones and urine-specific gravity Q-void to test for ketones and to test for hydration, and a series of nutrition-related labs for sudden changes while transitioning from a home regimen to a new diet that's focused on ketosis. This table reflects the patient's labs during their 3-day stay, in which during day 2, his blood glucose started to drop to an appropriate range, and he was showing signs of developing ketones. On day 3, patient was in a good state of ketosis, but did experience one episode of hypoglycemia at 48, in which some changes were made to his ratio, which will be discussed in a couple of slides. As for medications, for a ketogenic diet, it is advised to switch any liquid form of medication to tablets to avoid excess carbohydrate intake. That's if it is feasible. For this patient, cholecalciferol was switched to tablet form, but all other medications that were in solution form remained that way and were taken into consideration while calculating an appropriate ratio and range for this patient to remain in ketosis. For clinical assessment, while visiting patient during initial assessment, patient appeared as slender with minimal stores in his upper and lower extremities. Now for dietary assessment. His estimated energy needs were calculated using resting energy expenditure with an activity and stress factor between 1.2 to 1.4, which roughly estimated his daily caloric intake between 590 to 740 calories per day. I apologize, I said 1.4, I meant 1.5. In addition, his estimated protein needs were calculated at 1.2 grams per kilogram per day, and fluid needs were calculated using Holiday Seeger. Prior to admission, patient's formula was prepared using Elecare Jr. at 26 kilocalories per ounce. Patient would receive a total of 700 milliliters per day. During the day, he would get 4 feeds of 100 mLs of Elecare Jr. that ran over 1 hour. And overnight, he would get continuous feeds for 10 hours at 30 mLs per hour. And with that, he would roughly be receiving 607 calories, about 22 grams of protein, and about 75 grams of carbohydrates. During admission, we transitioned the patient's formula to keto peptide 4:1, following the same home regimen. So during day one, the transition was a 1-to-1 ratio using 2/3 of Elecare Junior and 1/3 of Keto V at 26 kcals per ounce. Day two, we switched over to a 2-to-1 ratio, which incorporated 2/3 of Keto V and 1/3 of Elecare. Again, keeping the formula at 26 kcals per ounce. And then on day three, we switched over to the goal of 3-to-1 ratio and switched over the calories to 30 calories per ounce using fully keto V peptide 4-to-1. And for carbohydrate intake, instead of using Elecare, since we were weaning him off of that, we decided to offer apple juice as a form of carbohydrate to remain in that ratio. So patient tolerated ratio changes appropriately during day one and day two of formula change, but on day three, as mentioned in the lab slide, patient did experience a low blood sugar of 48 prior to his AM feed. That said, to better tolerate formula and keep patient stable, his discharge formula recipe was changed to a 2.8-to-1 ratio, and the caloric change was changed from 30 kcals to 28 kcals per ounce to stabilize his blood glucose while helping him remain in ketosis. To finalize his inpatient monitoring, his nutrition diagnosis was unintended weight loss related to recent C. diff infection, as evidenced by 0.33 kilogram weight loss over the past 2 months. Goals for JP while inpatient was to tolerate transition to keto V peptide formula without significant intolerance, to have a stable blood glucose greater than 50, but no more than 75, and to demonstrate moderate to large urine ketones between 40 to 160. Interventions used to reach these goals included a new diet order of keto V peptide, a recipe prepared and advanced by the RD, as I showed the different days and the ratio changes. Um, Also, to monitor keto labs as ordered and mentioned earlier, to check blood glucose every 4 hours and offer 15 milliliters of fruit juice via G-tube, and to recheck blood glucose after 30 minutes to make sure a patient is stable. In addition to that, another intervention included checking urine ketones Q void to check for moderate to large ketones. And the RD was to follow up feeding intolerances or tolerances and to check labs to make sure patient is in ketosis. And as every day went by, the RD was in charge of adjusting the plan as indicated. So, in order for the patient to discharge, there was a couple of criteria that we want to make sure were checked off. First is, of course, tolerance to the keto formula. And to check for tolerance, we looked at the blood glucose to make sure it's stable, um, to make sure patient is in ketosis, and to make sure patient is tolerating feeds by not showing any signs of emesis, diarrhea, or hypoglycemia. Um, Also, another discharge criteria would be to educate parents on the ketogenic diet. So, with that, we offered parents a folder containing handbook. We educated parents on formula preparation and how every day the ratio changed for ketosis. We explained ketosis. Um, we also explained how to check ketones and protocol for blood glucose if patient was looking tired or low on energy. We advise parent to just offer 15 mLs of apple juice. And also, we offered parents letters for their primary care and ER, just in case they get admitted somewhere else. They'll have something ready to show that this patient is on a ketogenic diet and not to offer any dextrose. And lastly, before discharging the patient, we want to make sure they're going to receive their formula. since this is a medical use of formula. And as mentioned, for outpatient monitoring, we do want parents to check urine ketones 1 to 2 times per day for 1 month, just to make sure the patient is stable and staying within ketosis. We offer parents a seizure log, of course, to see the progress. Is this diet working? Is there a reduction in seizures, or are things staying the same? If nothing is changing, then why continue on with the diet? Um, Also, we want to make sure patients are having normal bowel movements because, as mentioned earlier, these patients do experience constipation. We definitely don't want that. Um, and then follow ups will occur via the phone or office visit. And if possible, we do ask for weekly weight check ins just to see if patient recipe has to be adjusted in any way. And then we request the office follow up in 1 month. Then after that, every 3 months, and blood work after the first month, and then following that every 3 months thereafter for the first year to make sure everything is stable. Thank you so much for taking the time and listening to my case study. And these are my references. Thank you so much.